Welcome to the Oral Surgery Fight Club podcast. This is a collection of mock cases in the field of oral and maxillofacial surgery in a question and answer format conducted on Zoom. Enjoy.
I don't really care about details, but are you saying that it's not as in-depth as, say, an orthognathic case or infection case?
Yeah, it's not at all. Like there's a fast, so let's go to the blueprint for a second. This is a fair thing. Again, just to disclose to everybody, I'm not giving away questions or answers to this exam. I'm purely letting you know what's on the blueprint, and we are running through mock cases.
Good deal.
All right. Handbook. Everybody can see my screen?
Yeah.
Yeah. So here's the handbook. They go through, stuff. They make sure the exam's fair. It's a good thing. Their election process, blah, 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 blah. Deadlines. All right. So this is the screen I'm focused on. They let you know what, they tell you this. Again, it consists of 3 sections. And, they let you know what section you're on. Obviously, I don't believe they'd tell you the exact case. But the fast topics here, examples of topics that may be covered within the focused additional short topics. The fast topics are, my screen is getting dark here. Aesthetic surgery, sleep apnea, hemorrhage, ethics, professionalism, pre-prosthetic, whatever.
Okay.
What they mean to say by this is, I think that they have the chance of like mixing it in. So there's a few different ones that they may give you. They could mix in a couple like professionalism questions. So they'll sort of, the fast topics, they don't have much time to go through these. There's like they're saying they may ask you a cosmetic case. They may ask you about OSA, hemorrhage, all that stuff. I have a case at the end of the day. I know 2 people signed up to present cases, but I have another case that kind of hits on some of these things. And I'm kind of excited. It's kind of a fun one. All right. So who's presenting first?
I know I'm one of the examinees today.
Yeah, I have a case, I think.
Nice, Colin. Cool. Thank you guys for bringing cases. That makes it really helpful.
Carla and Colin.
Yeah. I can go first. It doesn't matter.
All right. Sweet. I'm going to stop sharing here and somebody else can pick it up.
All right. Let's see.
Oh, we got everybody here. What's up, Albana?
Hey, what's up? Sorry, I was having some technical difficulties, but figured it out.
Nice.
How are you guys?
Really good.
Good.
Wait, everybody's like a month out now. You guys scared or what?
Okay, like 8 weeks. It's not.
Come on,
Carla, I was thinking the same thing. I was like, you mean 7 weeks?
Yeah.
Is anyone
trying to get more scared, but that helped, Ryan.
Is anyone taking? Is anyone scheduled on Tuesday morning?
I'm Monday morning.
I'm Wednesday morning or midday.
Actually,
I guess. Yeah.
I'm Monday afternoon. Yeah.
Oh, okay. Carla, what about you?
Wednesday, second session, I believe.
Oh, you're with me.
All right. Can you guys see my screen?
Yep.
Yeah.
Start time 9:06. Let's go.
All right. So let's go. All right. Albana, I guess this is your case.
Yes.
So basically you have a 17-year-old female in your office who has a congenitally missing tooth number 7. Past medical history is significant for asthma. These are her medications and allergies. What would you like to know?
Okay. So, sorry. So I would first start off with asking her questions about how she, like if she's ever worn anything in this area. I guess a congenitally missing tooth. So that kind of answers that question. I would ask her if she's ever had any orthodontics before. If there's ever been any other trauma to any of the other teeth. I would ask her kind of more questions about her past medical history. I would get a sense of her anxiety about this type of procedure and whether she's had any other surgeries before. I would also ask her her social history. And then I would get a panel and do a physical exam.
Okay, so to hit on a bunch of those things. So she had ortho in the past. This tooth has been missing since she was about 10 years old. She has been wearing a flipper that is now breaking, and she's really interested in having something permanent. Doesn't want a bridge. Her other teeth are healthy. Is really interested in implant placement. She's pretty nervous about it. Never been put to sleep before. Negative social history. Was there anything else that I missed?
No, I think that was all I asked at least, but yeah.
Okay. All right. In regards to her asthma, what can you tell me based on what medications she's on?
She is probably like a mild to moderate asthmatic. I would ask her about her inhaler use, like specifically how often she has to use rescue inhaler, whether she's ever been admitted to the hospital for an asthma attack, if she's ever been intubated for it, or required any inpatient type of stay, and what brings on the asthma specifically, like is it exercise induced, stress induced,
Yeah. So you mentioned mild or moderate. What are the classifications specifically?
I don't know off the top of my head. Sorry.
Okay. All right. Well, ever since she started on this daily inhaler, she hasn't had to use her albuterol in about a year.
Okay.
So.
Okay. Cool.
You move on to your physical and clinical exam. So this is what you see. Tell me what you're looking for in a clinical exam for an implant case.
Sure. So the first thing that I would look at, I would kind of start from the middle and kind of work my way out. So the first thing I would look at is maxillary midlines. Mandibular midlines are both intact. I would look at overbite, overjet, and her Engel's class occlusion. So she appears class 1 with maxillary mandibular midlines on. I would look at her both in repose and at smiling. So right now in this smiling view, she appears to show 100% tooth to show, along with about 3-4 millimeters of gingival display throughout from number 6 to number 11. And then I would look at interocclusal height to determine whether or not something is restorable, as well as mesiodistal width from this angle. And then
what limitations on vertical height do you have?
So less than 6 millimeters is clinically non-restorable, because there's not enough vertical height to even do a screw retained crown.
What's the height difference for a screw retained versus a cement retained?
So less, I believe it's greater than 8 is has to be cement retained, and then 6 to 8 is screw retained.
So if there's a lot of height, you can't do a screw retained?
Well, I guess you can. That doesn't disqualify you from a screw retained, but it has to be at least, I believe, 8 millimeters in order to do a cement retained.
So if you have a short vertical height, is there one that you have to use?
If there's a short vertical height, I believe it's just,
in other words, which requires more space?
The cement retained requires more space.
Okay. Okay. So what else? What is gingival biotype?
So gingival biotype basically describes the quality of the gingival tissue. It tells you about like the thickness of the gingival tissue that the patient has. So there's 3 different types: type 1, type 2, type 3. Type 1 is like the really thin gingival biotype, where essentially it's almost translucent. Type 2 is kind of like average. Mm-hmm.
Okay, you got that. What type does this patient have?
This patient appears a little bit blurry. I'm just like on my iPad, but it kind of seems like a type 2, like an average, essentially.
Okay.
Gingival biotype.
All right.
Not too thick. Not too thick.
So, like I said, this patient is 17 years old. Does that raise any red flags for you?
Yeah. So the biggest red flag that I have with this is the possibility of passive eruption. So the other teeth will kind of erupt downwards, and then the implant will stay the same height. So then what ends up happening is that the crowns will be different lengths over time. So my ideal goal is to wait till she's 18. However, she is female, so she does develop a little bit earlier than a male would. So there's some consideration to be had with potentially placing it at 17.
How could you tell if she's growing still or not?
You could get wrist bone x-rays. You could ask her if she's had any changes in her shoe size. You could also get cervical spine like lateral stops to look at the you know what I'm talking about.
Mhm. So during your planning, is there anything that you can take into consideration on the restorative aspect if you think there's a chance the patient may still get some late growth?
You could potentially make the crown a little bit longer because you could always just trim back a little bit on the crown. So you can get an additional 1 millimeter longer. I wouldn't go for 2 millimeters. It's a little bit too long. It'll be a little bit too noticeable. But you could make the clinical crown about 1 millimeter taller in order to potentially account for some passive eruption.
What about when we were talking about screw retained versus a cement retained? Do you think that could help?
I don't know.
Okay. So the patients really
I
insist
guess,
on.
sorry, to answer that question, you could make the screw retained because then you could always just change it later without possibly damaging the implant body. So yeah.
Okay. All right. So your patient's really interested in moving forward. They don't want to wait any longer. So what information do you want now in terms of your planning?
So I would then get a dedicated cone beam to this area because it's a congenitally missing tooth. So I would want to know what the width is from the buccolingual dimension.
Okay. These are some slices of your cone beam.
Okay. So I don't know the exact measurements, but to me, just visually
So it's
looking
about
at
2 millimeters. In its most narrow dimension, it's about 2 millimeters.
Okay, perfect. So then in that situation, I would tell the patient that unfortunately there's not enough buccolingual width to be able to place an implant. So then I would plan for a GBR in this area, guided bone regeneration. I would do a mix of, or I would just do, allograft in this area with a PTFE membrane, titanium reinforced PTFE, in order to gain the maximum width.
What other types of grafts could you do in this area?
You could also do a block graft in this area. So you could get her, if she still has her wisdom teeth, you could, at the same time of wisdom tooth removal, you could also take out a small portion of the ramus and then secure that here with a couple of screws and add some particular graft to it as well, along with the membrane, and then just wait a good 5 to 6 months for that to take.
What goes into your decision when you decide what type of graft you're going to do?
The biggest thing for me is the buccolingual width and then the patient's affinity to have a second surgical site. So if the patient says no second surgical site, then you're kind of limited to the allograft. And then if the patient's okay with the second surgical site, then maybe consider more of a block graft in this area, just given how thin it is.
Does tissue come into play when you decide?
Yeah, I think thinner tissue kind of would be a little bit more of a contraindication for the block grafting, just because it would tent out a little bit too much, and so there'd be a little bit more of a concern for blood supply versus thick tissue have more.
All right, so you're going to move forward with your particulate graft and PTFE membrane. Do you put any additives in it? Any biologics inside yours?
So in this situation, I would combine it with PRF, and then I would also add some BMP to it in order to kind of give it a little bit more, I guess, certainty.
Well, what is PRF?
PRF is platelet-rich fibrin. It's a conglomerate of the growth factors from a patient's own body that's essentially placed in there.
What's the difference between PRF and PRP?
So PRF is platelet-rich fibrin versus PRP is platelet-rich plasma. So PRF is more of a, actually don't know, I'm sorry, off the top of my head. All I know is kind of like what it looks like.
Okay.
I have to look.
All right.
I'm sorry.
That's fine. So
yeah,
you complete the graft. You get 6 millimeters of width facial-lingually. You have plenty of space mesiodistally. Are you going to do any preoperative planning in this case?
Yeah, so I like to do guided surgical placement. So what I would do is I would take an intraoral scan of this patient and then also do a cone beam, like an updated cone beam. And then I would merge those two files together. I would design my implant. I would design my surgical guide. I would print that. And then I would utilize that guide during the surgery in order to place the implant. Okay.
All right, you place the implant. Everything goes great. patient's super happy. They get restored. They're seeing you for 1 year follow-up. She actually is going to get her wisdom teeth out, but you take a look at the implant and you see this. What is this?
So it appears to be some, just radiographically looking at it, just bone loss around the implant. I wouldn't be able to tell them anything else outside of the radiograph, but I would need a clinical photo to go along with this, but I would be concerned for peri-implantitis.
Yeah, clinically you can see the dark gray coming through the gum tissue. It's a little bit red. It's a little bit irritated. When you probe it, it bleeds a little bit.
Yeah, so then I would diagnose this as peri-implantitis.
And what bacteria are associated with peri-implantitis?
Oof. Typically gram-negative anaerobes, but I don't know off the top of my head.
Okay, how do you treat peri-implantitis?
So what I would do in this situation is I would tell the patient she would need a second surgery. I would open the surgical site. I would debride all the granulation tissue, being careful not to damage the implant.
What
And
instrument are
then
you using?
I would use plastic like scalers, not
Do you know
titanium
of any
ones.
studies that compare different types of scalers?
I don't. Not off the top of my head.
continue.
So then what I would do is I would sandblast the implant surface, and then I would place some doxycycline around this area, and then some bone graft, and then close everything up.
Do you use anything to decontaminate the site before you put the doxycycline?
Yeah, you can just like EDTA on it.
Okay. All right, you're done.
Cool.
So I think that was like 13 minutes. So it seems really short, but I guess that's exactly how long it's going to be.
That's
Yeah,
crazy.
that was a tough case.
There's a ton of other questions I had, but I just was looking at the time. I wanted to keep it kind of realistic. So.
Ooh, I'm sweating, Colin.
I know Colin had some gnarly questions in there.
I know.
like
I was like, shit.
That's good.
I know. Is
I
making
also
my,
have not been the best at setting. So I've just been like, I moved and everything. And so anyway, yeah. That was just all Shafi knowledge. Just
Colin,
blurt it out.
the studies of plastic versus titanium instruments. Oh man, it made my pants feel one size too small. That's a juicy question.
Yeah,
that was a good one. How did I do though? Did I do okay? Like, I don't know.
Yeah, you did pretty well.
Okay, good.
I mean, the other thing I was trying to get at the screw retained versus cement retained prosthetics, and for a screw retain, you can have as low as 4 to 5 millimeters of height, but you need at least 6 or 7 for a cement retained. So those were the numbers I was looking at. The bone graft difference between PRP and PRF. So PRP is spun at a much higher speed, so it doesn't retain any of the leukocytes in it. So it's basically just platelets. But PRF is spun at a lower speed, so it retains the leukocytes, and it actually has the cells are less damaged, so it has a lot more healing potential than PRP.
Colin, I think, are you sure it's 4 to 5 for, what did you just say? Because I thought it was
For screw
45.
retain.
Yeah, you need, exactly. Okay.
Yeah.
You need more.
Hey yo. I gotta sharpen my swords for the oral boards. I learned him from Patel, and he's the Lord. And I'm his protege. I'm gonna slay all these motherfucking questions today. Cause I got the sound bites. They're gonna make these old men go, ooh, ah, like some afternoon delight. Yo, I got these questions in my sight, and I got the answers. Yo, my answers is so ill, they give you canker sores.
Thanks for tuning in to Oral Surgery Fight Club. For uncut episodes and sound bites, go to osfightclub.com.